Okay, I think we will go ahead and get started. Hello, and welcome to the first live forum in a series that we are launching here at PATH called Understanding COVID-19. My name is Elaine Gibbons, and I'm the Vice President of Global Engagement and Communications at PATH, and I'll be moderating the conversation today. Before we get started, I wanted to run you through a few logistics. Thank you to those of you that submitted questions ahead of time. We would like to hear from you during the conversation, so please share your questions and comments with us by submitting them in the chat box at any time throughout the presentation. I'll be looking at that chat box and we'll be saving the majority of the hour for your questions. The call is recorded, and just for those of you that maybe aren't familiar, you can see us but we can't see you. Please tag us at PATH Tweet during the conversation. And one note, although we are all on the West Coast, my colleagues and I, we have had challenges with local connectivity, as many of you will have experienced because of so many people working remotely. So we will do our best to keep both video and audio, but we may need to adapt that if it's challenging. So for those of you who are less familiar with PATH, we are a global team dedicated to achieving health equity so that all people and communities can thrive. And together we're driving public health solutions that meet the most pressing needs of families, communities, and countries. Our specialties range across vaccine research and development, diagnostics, drugs, devices, and health systems. We're a global team. We have a global footprint working in more than 70 countries around the world. Today, you'll hear from PATH's two top doctors and scientists, Dr. David Fleming, Vice President of our Global Health Programs, and Dr. David Kaslow, Vice President of Essential Medicines, who will share an overview of what we know about the pandemic and will answer key questions around product development and treatment options. These are testing times, and the overload of information sometimes doesn't help reassure us. But as an evidence-based organization, we wanted to offer our perspective about the pandemic, and we really hope it's useful to you. I want to thank everyone who is joining us today. Thank you for all of what you're doing in your community right now, both here in the US and globally. I know we have several of our closest philanthropists and partners on the call. Thank you for your incredible support right now. This is not a fundraising call, but we are absolutely fundraising at this point. Our work has never been more important nor urgent, and we do need the financial flexibility to respond quickly. I'm now pleased to turn it over to our speakers. We'll start with Dr. David Fleming, who has more than 30 years of experience in public health leadership. He's been the former Deputy Director of the CDC and is still advising them on the current outbreak, and used to lead the King County Public Health Department. His role at PATH, he oversees all of the PATH country offices and our public health programs, which includes a wide variety of areas, including sexual and reproductive health, maternal, newborn, child health and nutrition, malaria, HIV, AIDS, TB, and digital health. Thank you. Over to you, David.
Hey, thanks very much, Elaine, for that gracious introduction. And thanks to everyone who's joined this. We have a beautiful day, at least in the Pacific Northwest, and we appreciate you taking the time to chat with us today. You know, there's a lot of information that is out there, and I suspect we're all on a bit of information overload. So I'm not going to, by any means, try to be comprehensive. But if you would indulge me, I do want to show you 3 slides. My training, as Elaine mentioned, is as an epidemiologist. So the first 2 are just a bit of epidemiology. And then the last one are some of the top of mind issues that we're thinking about here to get the discussion going. So from a epidemiologic perspective, when you're thinking about a disease or a pandemic, as shown on this slide, there are really 2 key variables that we need to be considering. The first, along the x-axis on this slide, is how severe is the disease? What's the mortality rate? What are the clinical hospitalization rates? And on the y-axis is how transmissible is the disease? How easy is it to spread? So if you have an illness that's highly severe and highly transmissible, that's when you have problems. On this slide are shown the influenza pandemics that have occurred over time, with that one up in the upper right-hand corner being the famous pandemic from 1918, and then the ones that have occurred since then in the various circles. The COVID-19 is not on this because we actually don't know to the degree that we would like. I'll talk more about this, the severity of the disease and its transmissibility. In some ways, those are the top two key questions that we need to be thinking about. More on that in a bit, but next slide. This is the famous epidemiologic curve slide that has made flattening the curve part of all of our vernacular during this pandemic time. When you have a disease unchecked, as shown on that left curve, it can sweep through a society very quickly and potentially overwhelm the ability of the healthcare system and other systems to respond. In the absence of a vaccine or drugs to treat the disease, really the only measure that we have to lighten the load is to implement measures to slow the spread of the disease through the population, flattening the curve as is shown on the right. And that's really what all of us have been experiencing over the past weeks with our messages on social distancing, improved hygiene, etc. It's important to point out that flattening the curve doesn't necessarily mean that fewer people will become sick. It means that they will instead become sicker at a pace that allows for us to better respond, and hopefully will get us to that point where there are effective vaccines and drugs. But much of the discussion we'll be having today is about the measures that we are taking to flatten the curve. So the next and final slide. I wanted to just do a little bit of free association to get things started on some of the top of mind issues that we're thinking about today. This is a very fast moving process, as we all know, watching the news each night. And here's just a couple of the things that I pulled out that I think are important relative to things that we know and don't know. First is a bit more on the epidemiology. And one of the frustrations that I have and that people who are thinking about the epidemiology of this disease has is in some ways how little we still know about it. We are only seeing where the light is shining. And by that, I mean all of the information we have out there about cases, about increases in cases over time is really based on testing. And testing, as we know, is going to preferentially be done, number one, for people who are more severely ill, and second, where testing is available. And so all the information that we currently have is biased by that. We have media pundits and others talking about case fatality rates and how many folks have been infected. We actually know both of those numbers are wrong. The case fatality rates that are being reported are high because preferentially people who are the sickest are the ones that are most likely to be diagnosed. And the case counts that we have out there are low because we know there are a lot of infections that are not being diagnosed. People actually are being discouraged in places where there's not very much testing from coming in and being tested, even if they're symptomatic. And there's potentially a lot of asymptomatic infection that is out there. So there's still a lot to learn about this disease, about these two most important variables that are the ones that we need to understand. Second, we talked in that last slide about the curve, the epidemiologic curve, and as a corollary of the fact that we have incomplete information, maybe the biggest issue is that we don't quite know how far along that epidemic curve we currently are. Today in the United States, from a case count standpoint, about 1.4 people per 1,000 in this country have been diagnosed with COVID-19 disease. If you believe the modelers and the epidemiologists that say that ultimately this disease is going to spread through the population, we're looking eventually at infection rates that are more in the 600 to 800 or 60 to 80% range for the population as a whole. If we're only a small ways along the curves, we have a lot in front of us and a big problem. On the other hand, if asymptomatic infection and mild disease is not being diagnosed, and there are a lot more people who have actually been infected, we're closer to the end of that curve. And that's a key issue that we need to resolve. How do we do that? One thing that a number of people are looking at, and there will be more information probably just in the next week or two out on this is moving from not only testing for the disease, but also using serologic testing, testing for antibody. By doing this, we can determine not only who is sick now, but also who has been sick in the past, whether it was diagnosed or not. And it's really by doing that serologic testing optimally on really important populations, like in places, Seattle, New York, where this epidemic arrived earlier in this country, and looking particularly at samples from children that will be able to most rapidly get a sense of, okay, to what extent has this disease actually penetrated into our population more than those case counts that we have indicate, and we can begin planning for our response based on this better information. Second thing I wanted to talk about, given that I work with PATH, is a little bit about low and middle income countries, which is where we are focusing most of our attention. The first thing that we're thinking is that actually the next couple of weeks may tell us quite a bit here. This epidemic is slowly spreading around the world, and the way that it has been spreading means that it arrived earlier in places like Europe and the United States than in low and middle income countries, particularly in sub-Saharan Africa and South Asia. Whether or not the disease in those countries is going to assume the same explosive epidemic growth as we've seen in the US, for example, in the past couple of weeks is an open question, and is one that we will learn more about as now the disease has established a foothold in these countries, we learn more. It's important that we arm those countries with the testing that they need to determine the rate of spread, and that we learn from experience to date as far as how to assist countries in helping best prepare for the disease. One of those ways, as in the US and as in Europe, is it's still the healthcare system in those countries, the measures of it and its capacity that are the most important thing to be thinking about here as we're trying to flatten the curve to enable the healthcare system to better prepare. And so we need to be working very closely in low and middle income countries to understand the epidemiology of the spread of this disease in the healthcare setting, to assure that the personal protective equipment that is needed to protect healthcare workers is available, and to make sure that life-saving measures, which may be less ventilators because of the paucity of intensive care units, and more alternate measures for the delivery of oxygen for people who have pneumonia, are primed up and able to serve as many people as possible. The last point I wanted to make, and maybe it's obvious, but it's very sobering, is think about the effect in the United States on the social distancing and other measures that we've taken relative to our lives, our health, and our economy. And now imagine you're in a low-income country with a GDP that's a fraction of the US and a social safety support system that is weak to the breaking point. The health mitigation measures that countries are putting in place, the social distancing measures, the lockdown that have been so devastating here, are increasingly much more devastating in the countries in which we are working. And so one of the things that we really need to be worrying about is how to work with those countries so that these mitigation measures have as least a negative effect as possible as they're achieving their positive outcomes. And finally, let me talk for a moment about what's coming, which is the need everywhere to take our foot off of the social distancing brakes, to begin to return to normalcy, to begin to get our family lives, our communities, our healthcare systems, and our economies back up to speed. As the curve is flattening, as case counts go down, we need to do more than just thinking about how do we relax the measures that we put into place. Because if in fact we're not too far down that epidemic curve, the instant we do that, the disease will come back in full force and we'll be needing to repeat our actions again. So we need to be thinking about, in addition to relaxing social distancing measures, implementing measures to take the place of those more draconian steps to slow the spread of the disease. And in particular, first and foremost, we need to be thinking about implementing a rapid and intensive case contact, case identification, and case support mechanism so that as disease continues to occur, we can provide the support that is needed to people who have been exposed so they can actually go into self-quarantine and continue to have resources to take care of themselves and their families. So beyond just contact tracing, which traditionally you do when you have a drug or a vaccine to administer, we need to, in addition, be thinking about the social support network that we need to set up as a country and as a world to support people in doing what we're asking them to do. Second, we need to be learning more and taking advantage of the fact that as the disease spreads through our communities, some of us are going to be developing immunity. We can talk a bit more about this, but the best guess is that immunity for this disease does occur, at least in a short-lived way. And so as people become infected and then recover, they should be prioritized. We should be thinking about helping to identify them so that they can return to work in places that are the most important. In the healthcare setting, beginning to take advantage of the immunity in healthcare workers to figure out how to better triage patients, for example. And this is going to mean, in addition to gearing up testing for disease, gearing up testing, the serologic testing, so on a case-by-case basis, we can provide this needed information to individuals. And then finally, summer is coming. And there's a lot of speculation out there about the extent to which this disease might be less transmissible when it's warm. We don't know the answer to that. The best guess is probably to some extent. And so that's another element of this disease that we need to be evaluating very carefully, because that may be an additional mitigation strategy that nature will be helping put into place as, at least in the Northern Hemisphere, we spread into summer. So Lynn, I'm going to stop here. Hopefully this is food for thought for people about some of the things that we're actively thinking about and some of the things that we collectively need to be learning more about in the weeks to come. Over to you.
Thank you, David, for those opening remarks, and thank you to everybody who's putting in questions. We are gathering those, and we'll get to those shortly. But next, I'd like to introduce my colleague, Dr. Kaslow. So David is a physician scientist with more than 30 years of experience in vaccine research and development. As VP for Essential Medicines at PATH, that includes drug development and the PATH Center for Vaccine Innovation and Access. David leads all of our work to accelerate the development and introduction of life-saving vaccines for the most vulnerable children and communities around the world. David Kaslow, over to you.
Thank you, Elaine, for the kind introduction. So what I'd like to do over the next 5 to 10 minutes is to provide a very brief and very high-level overview of two topics on 2 slides: SARS-CoV-2 vaccine development and COVID-19 treatment. Maybe the place to start is just by defining the 2 terms I just used. So SARS-CoV-2 is the official name that's been assigned to the novel coronavirus that was originally known as the 2019 novel coronavirus. Whereas COVID-19 refers to the disease, be it the headache, the cough, the gastrointestinal symptoms, or the dreaded acute respiratory distress syndrome that I'll come back to in a few minutes to talk about. A way to think about these 2 terms is that one refers to the bug and the other refers to the disease. And as an example, Staph aureus is the bug, sepsis is the disease. Here at SARS-CoV-2 is the virus, and COVID-19 or COVID is the disease. So where are we in SARS-CoV-2 vaccine development? Shown on this slide is a snapshot taken at the beginning of this week in terms of where vaccine development has progressed since the 11th of January, 2020, when the SARS-CoV-2 single-stranded RNA sequence was first made available by authorities in China. And so what's summarized on the left-hand panel is truly an unprecedented number of vaccine candidates, 60 to be exact, that are now in what's called preclinical development in an unprecedented short period of time. It's been less than 60 days since that RNA sequence was made available. You can see in that panel a wide range of vaccine types that are being studied in research labs now, ranging from protein-based vaccines to DNA and RNA-based vaccines to killed or attenuated forms of either the SARS-CoV-2 virus itself or other viruses in which SARS-CoV-2 genes have been inserted, actually to trick the body into thinking they've been infected with the virus and causing the body to mount a protective immune response. In the right-hand panel on this slide is a list of the 3 vaccines that are now in the earliest stages of clinical development, called first-in-human or phase 1 trials. The first to go into the clinic were the so-called recombinant nucleic acid or viral vector platforms. Actually shown on the bottom of this slide is the timeline for the Moderna candidate that actually went from a sequence, as I mentioned, available on the 11th of January to the first participant immunized on the 16th of March, under 65 days from sequence to first shot. And that, again, is absolutely unprecedented. At this almost the same time that the Moderna vaccine candidate went into clinical trials here in the US, in China, a recombinant adenovirus, it's a cold virus in which a spike protein or S protein from the surface of the SARS-CoV-2 virus was inserted into this viral vector. That one entered first in human studies in Beijing. And then back here in the United States, just a couple of days ago, Inovio started a clinical trial using a small circular piece of double-stranded DNA. Again, a piece of a gene from the virus inserted into that little circle of DNA called a plasmid. And that is administered to humans with a short, small pulse of electrical charge referred to as electroporation. The Moderna candidate's been enrolling in 2 sites, one at Kaiser in Seattle and the other at Emory in Atlanta. And they've completed enrollment in the first 2 dose levels, the low and mid dose levels, and are finishing up enrollment in the high dose cohort. 2 big unknowns in SARS-CoV-2 vaccine development. First is, will these novel vaccine platforms actually work in humans? And second, and probably equally, if not more importantly, if they do provide an immune response in humans, is that response protective, or will it actually be associated with worse disease, as was seen in some of the animal models vaccinated with investigational vaccines and challenged with coronaviruses, SARS and MERS? And really only time will tell, so stay tuned. It'll be at least several months before we know whether or not we've got a candidate that not only induces protective antibodies, but does not cause immune potentiation or worse disease, and that could become available under either what's called emergency use authorization, or EUA, in the United States, or under emergency use listing, or EUL, by the World Health Organization. As tens to hundreds of millions of doses will be required, it seems quite likely that at best we're looking at 2021 before an investigational vaccine is widely available under emergency use conditions. Okay, well, let's go to the next slide and talk a few minutes about therapeutic options for treating patients with COVID-19. So shown at the top of this slide is a statement as of the 7th of April 2020 from the U.S. Centers of Disease Control and Prevention, or CDC, which simply states that there are no drugs or therapeutics approved by the U.S. FDA to prevent or treat COVID-19. And so what really remains the cornerstone of current inpatient treatment is actually largely supportive. It's fluid management, it's high flow oxygen, including intubation for mechanical ventilation, and when indicated, antibiotics or steroids. But what's being studied? And the way I think about treatments in it, is in really 2 classes. One called drugs or small molecules, shown on the left, and the other biologics or large molecules, shown on the right. On the drug side, 2 approaches are being taken. One is to repurpose drugs that already exist and are licensed for other indications, such as HIV treatments or malaria or autoimmune disease treatments, and those that are still investigational, including one that was originally developed for Ebola, but is now being evaluated for treating COVID-19. The other group of therapeutics are referred to as biologics or large molecules, and that group are biologics that are largely used to modulate inflammatory diseases like multiple sclerosis or rheumatoid arthritis, or antibodies either those collected from patients who've recovered from SARS-CoV-2 infections or monoclonal antibodies that are directed at that spike protein, that protein that sits on the surface of the virus and is thought to be the target of neutralizing antibodies. I did want to draw your attention to a very large global study called the Solidarity Trial that was launched a couple of weeks ago in coordination with the World Health Organization in over 44 countries. And that trial has 5 arms to it. One arm is testing that HIV drug combination shown on this slide called Kaletra. Although it's worth noting that in an early study of that combination in China had actually pretty disappointing results. So the second arm is that same combination of HIV protease inhibitors in combination with a multiple sclerosis drug shown on the right-hand side called interferon beta. And that interferon beta is added because it's an immune system messenger that's known to cripple the replication of virus as they replicate in human cells. The third arm in the Solidarity Trial is that experimental direct antiviral drug that was originally developed to treat Ebola. Again, just noting that the results of that drug when used in Ebola were rather disappointing, but time will tell its effect on SARS-CoV-2. The fourth arm in that Solidarity Trial are the malaria medications, chloroquine and hydroxychloroquine. And as you probably have heard, those malaria and autoimmune drugs are being looked at in combination with an antibiotic called azithromycin, plus or minus zinc. One thing to note is that chloroquine may need to be used in really high doses in order to be effective against SARS-CoV-2 infections. And those high doses are associated with heart complications, which mean that we've really got to manage the use of those drugs very, very carefully. And then finally, the fifth arm in that Solidarity Trial is simply the standard of care, which I mentioned previously. In addition to the Solidarity Trial, there's a number of protocols that are looking at a variety of, again, repurposed and investigational drugs for the prevention of infection in healthcare workers and in household contacts, and it includes some of the drugs that I've already mentioned and many more. The one treatment on the biological side that does look quite promising in some early results is something called interleukin-6 receptor inhibitor. And it's a treatment that's used in and licensed for use in rheumatoid arthritis. And this biologic is thought to be a really good anti-inflammatory to fight that so-called cytokine storm that's associated with acute respiratory distress syndrome. And so 85 patients have now been enrolled in 22 sites in the United States to see whether or not that rheumatoid arthritis biologic can be repurposed to really dampen down that immense inflammation that's caused that results in that acute respiratory distress syndrome. And then finally, I'll quickly mention that various monoclonal antibodies are being developed with antiviral effects. Most of those are at least 3 to 4 months from the clinic. However, the convalescent plasma collected from patients who recovered from SARS-CoV-2 infections are already being tested in the clinic. And I think, Elaine, in the interest of time, I'll pass it back to you.
Okay, thank you, David. Very helpful and a good broad overview there. Thank you for those remarks. I think we are going to move now to questions as we are at the half-hour mark here. I think, David Fleming, I'm going to pass it back to you. Lots of questions on testing. So I know we did touch on it a little bit, but I wonder if you could talk a little bit more about widespread testing, and in particular on the serologic tests. When will they be available widely and for whom?
Sure, thanks, Elaine. And this is a rapidly evolving area, so it's important to talk about it and think about how we can move rapidly with this. Just to take a step back, once again, the testing that is common out in the world now is testing that actually looks for the virus when someone is actively infected, and is a very good test to know if they are sick. But as people recover from the virus, they do develop antibody, that is clear, and serologic tests are blood tests that look for the presence of that antibody. In that sense, they are a very good marker for someone who has already been infected and presumably now has at least some immunity. Those are the tests that are under rapid development now. There are many different entities, both in the government and the private sector, that are currently working to develop these tests. One has actually been provisionally licensed by FDA. But these tests in some ways are a little more of an art than a science compared to the tests to detect the presence of the virus. And so it's very, very important that these tests be standardized, and in particular, before they're used widely, tested extensively against a wide variety of blood specimens from people who have not had COVID and a wide variety from people who have, so that we know that they are highly sensitive and highly specific. Some of the early serologic tests that were developed did not have those characteristics, and so folks are working hard to develop, in essence, a second generation. There are some good research tests out there now. CDC has one. We need to validate them and then get them into the commercial private sector so they can be scaled up. The two primary uses for these tests are, first, on more of an epidemiologic investigation basis, to rapidly use them to test small samples, population-based samples of blood from people in different parts of the country, so that we know the relative infection rates in different parts in this country. It'd be also useful, and we're talking about this with CDC, to try to conduct similarly designed studies in other parts of the world, in Italy and Spain and China, so that we can get a better sense of whether the epidemiologic picture that we're guessing at a little bit from the case counts is actually supported by these serologic testing results, which give us far more accurate information. Back in the early days of HIV, it was really widespread serologic testing of blood specimens in different populations that gave us the first, best, hardest information about who was infected and what the risk factors for transmission were. So I hold a lot of hope out for these, and as I say, Seattle has been one of the first participants, and we're anticipating that some early results, even from Seattle, could be out within the next couple of days to next couple of weeks. But that's just the beginning of a broader serologic study. Second, though, potentially these studies could be useful on an individual basis, a case-by-case basis, to identify which people have been sick and therefore potentially are immune and can return to work, return to key occupations, can be used potentially even in the healthcare setting to help triage the care of sick patients with healthcare workers who have immunity. Obviously, there's a lot of unknowns still. We don't yet know the degree of immunity that people get from this. That's something we can only determine over time. We don't know how long it lasts. We don't know for sure whether people can become reinfected after they've already had the disease once. Time will tell. The best guess would be, again, that most people will develop some sort of immunity that will confer protection to them, at least for the short term. And that's why I think that thinking about these immunologic tests on a case-by-case basis in the population poses one of the important ways that we can minimize the return of this disease after we release our social distancing measures by a smarter use of existing immunity within our communities.
Mm-hmm. Very, very good. Thank you, David. David Kaslow, I wonder, lots of questions coming in on all aspects of vaccine development and introduction. But before I ask you a question on that, would you like to add any additional comments around immunity from infection on COVID-19, in addition to what David Fleming just noticed?
Sure, yeah. So the short answer in terms of what we know about immunity is, as David alluded to, is certainly not enough. And really knowing more about it's going to be important from, as David mentioned, kind of two aspects. One is what's the risk of becoming reinfected? But in kind of my part of the shop, what's going to be really important is what can we learn from that immunity in terms of vaccine development. It's probably worth mentioning, again, small study, but I think it's worth mentioning that there was a recent publication from Shanghai that reported looking at plasma collected from 175 COVID-19 recovered patients who had mild symptoms. And what that data showed was there was a high degree of variability in the immune responses elicited from a mild infection. Interestingly, elderly and middle-aged patients had a significantly higher neutralizing antibody titer. And what that means is that when you add the antibody, it blocks the virus from infecting cells when compared to younger patients. Why that should be is unknown. But probably what was a bit concerning from that study was that there were 10 patients who had absolutely no detectable antibodies, and particularly no detectable neutralizing antibodies. And really only 2 of those 175 had elicited very high levels of neutralizing antibodies. Yep, it's just one study, actually a rather small one. And so clearly we don't know enough about immunity, and we really need to, if we want to better assess the risk of reinfection and better help drive development of a safe and effective vaccine. Back to you, Elaine.
Yeah, and let's just continue on maybe the questions there about vaccines. Is it what is your view about whether it's possible on a global scale to have expedited delivery of therapeutics or a vaccine globally? Could you address that?
Sure. It's certainly possible, but only if we, one, reject business as usual. We've got to have a paradigm shift from the way we conventionally develop both vaccines and therapeutics, which is this conventional phase 1, phase 2, phase 3, regulatory review, policy review, and then final financing to actually make these things globally available. We've got to get away from that into something that's more of a just-in-time, highly adapted, almost seamless decision-making through that continuum, so we can accelerate development. And I think we really need to think completely outside of the box in terms of how are we going to manufacture and deliver billions of doses of either drugs, biologics, or vaccines. And to be honest with you, in my mind, yes, there are biological barriers. Yes, there are technical barriers. But maybe one of the biggest barriers that we've got to overcome are some of the human-made barriers in terms of how we think about doing drug development, how we think about regulatory review and policy making and financing, and how we think about manufacturers working together rather than competing with one another in the marketplace with products. So if we can overcome those, yes, I think it is possible.
Mm-hmm. It's a big if, given the current environment on much of this, but I think that if there's ever a situation that merits that new way of thinking, it's now, and I credit many of my colleagues at PATH, in your division in particular, David, for bringing that innovative thinking not just to the product work that we do and not just to the downstream implementation work that we do, but how we think about policy and financing and partnership across into the private sector. So I have some hope also. I'd like to pivot a moment here, David. David Fleming, we've had a few questions here that relate to something that you and I have talked a great deal about, which is the impact on other disease areas in the low-income settings in which we work. So the question is, are your teams finding that other health programs are in jeopardy as resources are allocated towards COVID-19 response efforts?
Yeah, it's a great question, and sometimes we think of pandemics as affecting everyone equally, but unfortunately that's not the case. This is a disease, including as a result of the mitigation measures, that is going to disproportionately affect those people in those healthcare systems that are the weakest. So the short answer is that yes, in low and middle income countries, there is a significant and increasing risk of spillover effects from our COVID-19 response to other disease areas, not so much because resources are being pulled away from those areas, but rather the healthcare systems overall are strained, going through many of the same things that we're thinking about now. A couple of examples would be, we do know this disease unfortunately is transmitted fairly effectively among healthcare workers, and so as the healthcare worker workforce becomes infected and gets depleted, that's not limited to the treatment or the services that they're providing to COVID-19 patients. That's a general effect for all patients. In addition, there's a lot of fear appropriately in countries. And so particularly on some of the services that are preventive, we're already hearing that in immunization clinics, for example, parents are thinking that it may not be worth it in this time to bring their child into a very crowded immunization clinic full of other kids and parents to get that vaccine because of the risk that this disease poses. Finally, as we think about the mitigation measures that are being put in place in these countries, we need to recognize the profound economic effect they're having on people, particularly those that are already most vulnerable. And so the ability of those people to seek services in many of these systems which require payment is already diminishing and is going to continue to diminish further. Unfortunately, this is a place where the preventive measures that we put in place for preventing the spread of COVID-19 have very significant ramifications to the rest of the healthcare system, to the health of communities, and to the economy of communities. And that's, in some ways, a more predictable effect than the unknowns that we currently have about the disease itself.
Yeah, it's going to be a very difficult time, I think, for many of the communities in which we work, and that, of course, does include the United States, just in terms of the communities in which we live. And I'd like to broaden it out a little bit, maybe, David, to talk to you about and get your opinion on topic, again, that you and I have discussed, and you've been very vocal on, both here locally and in the global work that you do around equity. So, of course, recent reports in particular of Black Americans being disproportionately impacted by the disease and dying at rates faster than the average. So no doubt, I think, while there was an initial idea that this pandemic could be an equalizer and that we're all facing it in the same way around the world, we're absolutely not. And it doesn't affect everyone in every community in the same way, and our response can't assume that. I wonder if you could reflect around that and sort of talk to us a little bit about the importance of equity in our response.
Well, that's a really great introduction. You've said many important things there. And, in retrospect, but even looking forward, we know that the underlying conditions of inequity in our communities are going to drive the ultimate outcomes that we see with this illness. We know that people who are economically marginal, who live in poor communities, are going to do worse, and we're already seeing that. We're already seeing, as a result of some of us being able to operationalize these social distancing measures easier because of our affluence, that the poor are getting more infected more often. We're already seeing that access to healthcare, which is a privilege in our country for the affluent as opposed to a right, is influencing the disease outcomes. And we already are seeing that many of our populations, particularly the African American population, which has a higher prevalence of the underlying conditions like hypertension and diabetes that put people at higher risk for death, is playing out in the mortality rates. So this is in fact a measure of the inequity that we're facing in the US and around the world. And I would put out that if it's not a silver lining, but a commitment that we all need to make is not only to do the right thing to assure that these individuals who are being disproportionately affected, that we do everything possible to help them. It's actually in all of our interests. And by that, I mean, at the end of the day, we are only going to be successful to the extent that the control measures that we're putting in place, the social distancing, asking people to forego work and instead self-quarantine are done by everyone. So as we're thinking about the strategies that we need to incorporate into this country's next wave of response as we release social distancing, we need to recognize that they need to be supported by systems that make them equally accessible and equally effective to everyone, regardless of their race, regardless of their income, regardless of their ethnicity or underlying diseases. So it's in all of our interests, actually, to assure that we do everything possible to recognize the inequity that this epidemic is causing and move rapidly to fix that to the extent possible. I don't feel passionate about this at all, Elaine.
Yeah, we could tell, David, but it's essential, and I think it is really laying open for everybody on a global scale now to see the challenges here, both in this country and globally. David, Kaslow, a couple of a very specific question, I think, which I'd like to direct to you, and then I'm going to bring it back to a concluding question I'll ask for both of your reflections on. So, David Kaslow, what is PATH's role with the WHO in all of this?
Right, and the WHO, I think, at least in my opinion, plays a critical role at the global level, at the regional level, and also at the country level. At the global level, clearly, and this is something that I'm personally involved in, along with a variety of other partners, is they've organized something called the Global Coordinating Mechanism that's associated with the WHO Blueprint for Research and Development on Priority Outbreak Pathogens. And basically what's been happening for several months now is that Global Coordinating Mechanism meeting gets together, we share information in a confidential setting that really allows everyone to have better insights into what all the partners are doing, and really getting back to that thought that if we really want to be able to deliver on a global scale, we're going to need to think outside the box. We're going to need to think about how do we partner in a different way. And part of the WHO's role here is to provide that forum for that. In addition to that, they're leading the way in thinking about things called master protocols. Again, out of the box, this is not business as usual, where you take different drug therapies, as I mentioned in that Solidarity trial, and there's a similar vaccine protocol where you take different vaccines in the same trial and compare them head to head against the control to really be able to make evidence-based decisions in terms of what we should be investing in terms of treatments and in vaccine development. And PATH is playing a role in terms of looking at those protocols, designing those protocols, and then when in this case, vaccines get to the point of testing, actually being involved in the implementation and testing of those vaccines. So WHO is playing a critical role in PATH. I'm glad to be a partner in that effort.
Yeah, and maybe as we're wrapping up here, coming closer up to time, a few questions have come in around the role of PATH, actually. So how flexible are we in terms of our ability to respond? Is there coordination across teams? We are known as an innovation organization, I think. That is, as we've talked about, not just in the product space, but across a variety of different disciplines. How would you both respond to that? What is PATH's role here, and are we able to be flexible and to drive some of that creative thinking that clearly is so necessary? David Kaslow, I'll start with you, and then let's go to David Fleming.
So I'll take it from the kind of the product development side of things, and what our role is, and what our role has been for decades now in product development, is identifying where the gaps are in partnerships and filling those gaps with technical assistance, technical expertise, being that kind of neutral, objective entity that pulls the data together and really makes an objective look at the data to try to drive the best and optimal products forward. Meanwhile, working with entities, normative bodies like the WHO, financing bodies like Gavi, to do what I talked about earlier, which is to try to accelerate that development pathway and to move it through, and when we're business as usual, the conventional one, but when we're in a situation like a global pandemic, rethinking that conventional pathway and really figuring out how we can streamline it and accelerate it and get these products out where they're needed most, which is in low and middle income countries, low resource settings.
David, Fleming?
Yeah,
Perspectives?
boy, PATH prides itself on innovation, and I can't think of a situation where innovation is more needed than the one we are currently in, where we have such a lack of knowledge and such a need to develop rapid action. So we're focusing on, first and foremost, in partnership with the countries where we operate, providing near-term, immediate, almost emergency support to the ministries of health to help them with manpower, with thoughts, with ideas, with learnings from the other parts of the world to prepare in the short term for what they may be facing. It's kind of it is a crisis, and it is, let's make sure that we deal with the urgent first. But then, as we talked, in addition, we do need to take a step back and say that this is a game-changing event, and will likely be that in many of these countries that will go well past their initial immediate response. And so we are already working with countries, with our donors, and with our partners to be saying, as we're helping to prepare for what is immediately coming, let's not be so short-sighted to ignore the longer-term effect of this with respect to its effect on the healthcare system, with its effect on health equity, as we've been talking about, and begin even now to come up with those good ideas, identify the financing, and begin to put the systems in place that are needed in the future. The world has really been able, in the past couple of global disease outbreaks like Ebola or SARS, to say in the immediacy of the moment, oh, we need to do more in the long term to strengthen our systems, to make sure that our countries and our partners do better. But that has fallen off the table. I think that there's a good chance that because of the magnitude of this epidemic, that we're in a unique situation to actually put into place those needed innovations that we know are important for the short term, but also to begin to plan for the long term as well. In that sense, if it's a very small silver lining, there's a silver lining here that if we're smart now, we can be better prepared in the future.
I would agree with that, and as somebody who has responsibility for the advocacy and policy work, I would add that an area of real focus for us is to think in the long term about policy implications and how that can help drive solutions at some scale. And so I think there is some hope for change in the future. I think we will begin to conclude now. We're coming short to time. So thank you to David and David both for your thoughts and your remarks. And thank you to those of you that joined us on the call today for your questions and your insights. If we've not been able to answer all the questions, we will look to try and address many of the issues that have been raised here in upcoming content that we can distribute, and also in our upcoming calls of this nature. As a reminder, this is the first one in a series, and we are hosting the next one next Tuesday, April the 14th at noon Eastern Time. And it will take a look more deeply at epidemic preparedness responses in Senegal. We're happy to be welcoming the Director of the Senegal Emergency Operations Center and also our country director, Aminatou Sarr, and our Director for Global Health Security, Linda Vencel. Excellent panelists for next week. So I hope you will consider joining us if you're able. You can find out more about our response efforts by visiting path.org, of course, and thank you to our donors for all of your incredible support. We would welcome that continuing. Many thanks to everybody today, and please stay well. Bye-bye.